Okay, first of all, good evening to all of you. Dear Marc-Antoine, thank you for the invitation for this webinar. I already followed the first and second webinar meeting, and I think it's very valuable and beneficial for surgeons who want to learn more about the procedure with total disc replacement and their advantages, as well as the experiences until now. So here are my disclosures. I was trained as a general surgeon and orthopedic surgeon and trauma surgeon as well, and was able to perform more than 1,000 lumbar discs and 2,000 cervical artificial discs myself. During the last 20 years, I've been able to gain experience with intervertebral disc prosthesis of different types, designs, and brands. During this time, I developed a treatment algorithm that focuses on clinical outcome and patient safety. On the following slides, I would like to present my principles and challenges after cervical disc replacement. When does the post-operative course start? So I think after wound closure, post-op care starts and begins with quite simple things like using always a retropharyngeal drain. Remember, due to the preparation, you pass many vessels. Bleeding of different veins may result. Epidural veins, jugular veins, segmental vessels, or thyroid superior artery, to name a few. Also, when using the Casper retractor, the pin spot may bleed after the screw has been removed. Using a soft collar, the size must be measured pre-surgery. You have to measure the size between the chin and the breast, and you have to make sure it fits proper to limit motion after surgery. We check our patient before he leaves the OR if the brace is fixed proper, and we always use the retropharyngeal drain. Before patient leaves the operation room, we check if the drain is proper fixed and the drain bottle open. So why using the soft collar? It is recommended after cervical disc prosthesis implantation to limit movement of the cervical spine and improve bone integration. Several studies have shown that the bone integration is improved by coating with HA, hydroxyl apatite. We are currently assuming that the bone integration has reached a strength of 80% in the first 6 weeks after implantation as a result of bone growth. Post-operative, check the patient with neurological examination and control the phonation. First night, my patient is controlled and observed on the ICU. The drain can be blocked or occluded at the top, so bleeding may occur and the problem cannot be identified. Dysphagia and dyspnea may result. In normal post-op situation, drain will be taken out after 1 day after surgery. AP and lateral X-ray will be done, and the physiotherapist will start local massage, electrotherapy to reduce neck and shoulder pain due to the segmental distraction of the spine. Most restrictions I recommend for patients are for 6 weeks, like self-driving the car, swimming or cycling, hyperextension in the neck, heavy lifting over 5 kilograms, only isometric training for first 6 weeks, and contact sports are allowed after 12 weeks. Wear neck brace for 3 weeks and then, depending on the compliance of the patient, another 3 weeks. Bone integration is expected 6 weeks post-operatively, so I see my patients 6 weeks after procedure and control by X-ray and clinical examination. There's one challenge and complication I want to focus on. It's really rare, but still can happen. A 46-year-old female patient was planned for surgery in 2 levels due to neck pain, disc herniation, arthrosis. Operation went smoothly. Due to the protocol, she was observed on the ICU. Monitoring after surgery, patient complained mild symptoms of coughing. Pre-existing pain was gone, neurological examination was quite normal, and an X-ray was performed. We found an increase of the distance between the trachea and the spine. Revision surgery was initiated and about 180 milliliter of blood clot was removed. No active bleeding was found. 2 drains were inserted, and a couple of hours revision was done. Revision drains were taken out, and X-ray was performed and showed nearly a normal anatomical situation post-surgery. The literature has repeatedly challenged the use of surgical drains following many procedures, and there are currently no guidelines for determining which patients are most likely to benefit from drain placement after cervical disc replacement. So nonetheless, neck hematoma is still possible, even with a drain use. After cervical surgeries with total disc replacement, patients should be closely monitored. Although the risk of secondary bleeding is rare, it requires a rapid and consistent action. Drains can help to detect bleeding, but they are not a guarantee. A soft collar is recommended after cervical disc prosthesis implantation to limit movement and improve bone integration. Thank you for your attention.